Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Today, I'm excited to be joined by Dr. Carole B. Lewis. She has so many certifications and degrees after her name. I want you to check the messages to look at this. It's just amazing. She's an editor-in-chief, Topics in Geriatric Rehab. She's the president of Great Seminars and Books and Great Seminars Online. She's a practicing physical therapist and an adjunct professor at George Washington University, Department of Geriatrics, College of Medicine. She is an expert in the area of bringing hope and skill to a group that too many people overlook and underestimate. I love that. Helping our patients who are weak, deconditioned, and frail. We'll be diving deeper into this important topic, including recent research and actionable takeaways you can implement right away. Welcome, Carole. I'm so excited that you're here. Can't believe it that I get to talk with you.
No, I'm excited. Thank you so much for thinking of me and asking me to do this. And thanks, MedBridge, for your, invitation. And I'm excited to share some time with you.
Yes.
So we'll chat.
Yay. So I'd love for you to get us started just sharing a little bit more about yourself.
Gosh, I've been a PT since the 70s. Now, I know people weren't even born then listening to this. But yeah, I've been a PT back when we were not doing the kind of things we're doing today. We were under doctor orders. We couldn't, get initial referrals. It was a rough road back then. We have so much more now. So yeah, I've been a PT for 50 years. I went to PT school at Ohio State, the Ohio State University. And then I got 2 master's degrees at University of Southern California. It was a 2-for-1. There was a gerontology and a public administration degree that I was able to get,
nice.
Which was great. And then I got a PhD in health education, but it is now, it was this weird degree. It was health education, but it was really more like public health. And now the school, there is no health education school. Now it is the School of Public Health, but it is a PhD in health education. And then I have a bunch of certifications, but my real love is geriatrics. And that's what I love to do. Now, in terms of work, I've kind of worked everywhere. My first job was at LAC USC Medical Center, a 3,000 bed hospital.
Holy crap.
Yeah. In the 70s, they had wards, with 10 people on a ward. So a 3,000 bed hospital where you did 6 rotations through everything like neuro, burns, orthopedics, medical, med surge, and outpatient. So you did all these different, and pediatrics. So I rotated through all the different ones. Then I got my master's and had like 3 jobs. I was at acute rehab hospital. I worked in home health, and I worked on a skilled nursing facility, 4. And then on Saturdays, I worked in a sports medicine clinic. So I've sort of done everything. Then I moved to DC, and I opened up a clinic that ended up being 3 clinics in the DC area. And I sold them about 10 years ago. We were one of the first to sell to Pivot. You've heard of Pivot.
Yeah.
And so we were one of the first clinics to sell to them. So now I just do cash-based therapy with older adults. But my love in all these settings has been older adults.
Oh, so you haven't done hardly anything.
Yeah, pretty much.
And don't you have like a whole lot of books out there and articles? And
I do. When I was at USC, working, I realized there was nothing in geriatrics. There wasn't even a medical specialty. So I found the USC program, and I was in like the second year. First year was sort of this pilot year, but I was in the second year. So it was a gerontology program. People are like, gerontology, what are you doing? And then they started a specialty in medicine, and I was one of the I think, 10 people in APTA that started the specialty in physical therapy. And I wrote the first book in the 1980s. And then since then, I've written maybe 19 others. And I've edited a journal for it's going on its 42nd year, an international journal called Topics in Geriatric Rehabilitation, which I love because I get to see papers from India and Japan and China and Iran and, you name it, Scandinavia. And it's just so much fun. So yeah, I do. And I teach. I've taught all over the world in like 49 states. Guess which one I didn't do?
What? Alaska?
Yeah, good guess. I haven't done Alaska. I've been to Alaska, but I haven't taught there. And then I've done 14 countries. And I have a seminar company that does live seminars and some online courses, of which MedBridge has some. And I've been doing that for again, probably 30, 40 years. So I really love teaching and I love seeing patients and I love sort of pulling the research together and then using it on my patients and sharing it with others. So that's sort of my heaven, my favorite place is doing that.
Well, I'm so honored to be here because, I've known you forever throughout my career. So it's just a privilege to have you here. And it's just impressive how much you've worked, for this population and how much you've dedicated to it. So what initially attracted you to this population when they were like gerontology? Like what's going on there? Where was that passion?
Yeah. Well, I guess the original passion occurred when I was 5. And my grandparents took me to Florida. I know you're going to find this hard to believe, but I was a hyperactive child. And my younger sister was born and my mom went, I'm not doing 2 of them, so she had my grandparents take me to Florida for a couple months and I had a ball. I was with all these old people and they were so nice to me. They gave me gifts. They let me win a bingo. And I just had this place in my heart for them. It was great. Anyway, so I think I carried that with me, even though when I graduated PT school, I wanted to go into pediatrics. That's what I wanted to do because I had volunteered at a cerebral palsy camp and I loved that. And, when I did my rotations at USC, I saw that older people just weren't, I knew there was a specialty in pediatrics, but I thought, why isn't there something for older people? They are different. And I started thinking like that. And that's what drove me there because I'm one of those sappy people that watches those movies. And when, you see old people do these wonderful things, I cry, it's really, so it's here. It's really deep in my heart. So it was great for me to have a venue and a way to pursue that, so it really at USC, it set it off that I'm going to work. This is, I think, what I'm meant to do.
Well, it's interesting is that I remember when I was about that same age and my mom used to take me with her, 'cause she was a PT, to the nursing home with her in the morning. And so we'd go to the nursing home with her in the morning and then she would take me to her clinic. And so same thing, everybody would give me gifts and sodas and so it's just it grows dear to your heart. So
isn't that great? Your mom was PT. I think that's so cool that you decided.
Absolutely.
My kids didn't want to go into this. I think it's because I worked so much that they never saw me. I was a little addicted in the beginning. I was working like 60 hours a week, with the lecturing and the clinic. And I think maybe I wanted them so bad to go into the field, but they're both engineers. So I'm glad your mom did that and you loved it. Oh, that's so great.
Absolutely. So why do you think it's important to discuss the clinical challenge of working with this population in terms of your expertise and payment and just in general?
Well, okay. So I think of all the populations that we can really help, this is it. I know we do great things for people who have rotator cuff tears or, medial collateral ligament injuries. But, at some point, I think our skill level is so important for people that are frail, sarcopenic, and deconditioned, and then have a diagnosis they need to see us for, like a hip fracture or balance problems. When you see somebody who's younger that has a rotator cuff tear, you're looking at a rotator cuff tear. There's usually not all that other stuff going on. So yes, you can do a great job as a therapist. You can get them better, but the group that really needs you is this older group that needs, you're not going to go to Chat GPT, and put in, give me a program for, if you put in such a complex patient, Chat GPT will go blah, 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 blah. It won't be able to do it. But if you put it in for a rotator cuff, you can actually get a program. So, I think for us to do the most good would be to really find people that can use our services. Now, again, I'm not saying don't treat these patients, but if you have the opportunity to treat those more challenging patients, I really think you're making a difference. I think it's tough in the system we have because, all of physical therapy doesn't get paid enough, and I think at some point, I always believe that we'll be recognized for what we do. But I think at some point they're going to realize how valuable we are, because if we can keep people out of the hospital and from breaking their hips, it's so much better than paying for the MRIs and all the expensive procedures once they've broken a hip. So, I do think it's tough because of the time constraints. It's tough because of the payment, but I think it's challenging and incredibly rewarding because you give people back their lives.
And it's so fascinating is that when you feel that pressure of, I don't have enough time, it kind of means to me, like, you have to challenge them more. Don't underestimate what they're capable of doing. Do you agree with that?
Yep. No, I do. Yeah, I think I agree.
So but on that note, challenging your patient, because I think neuro, I think got to increase intensity, and then we add, we have our aging adult population or a combination thereof, and we have all these other things that have happened to them. And like, what should we be asking as clinicians to be able to make sure we're making the best choices for our patient?
Yeah, I totally think therapists are great at, when they're presented with a diagnosis, or even not. Oftentimes I just get, see Carole, and you have to,
there's a script
figure out what it
there.
is. Right. So, and so you get it from the patient, what it is, what's the issue? Is it, they're not walking, they're falling, they feel weak, whatever it is. I think, or my shoulder hurts and you figure out it's either OA or rotator cuff or, whatever. So I think we're really good at that. What I would love for therapists to do is recognize that there's really three overlays. There's deconditioning, there's sarcopenia, and there's frailty. And I think, understanding each of those, and it's not easy. So wait a second, I'm going to pull up, because I pulled it up so I'd have it for here, the definition of frailty, which is an aging-related syndrome of physiological decline characterized by marked vulnerability to adverse health outcomes, blah, blah, blah. In other words, there's some syndrome pretty much that causes you to, because you have that, just having, this syndrome makes it so you're not going to do very well. So really, how do you understand the syndrome? Well, Freed came up with 5 things, and these are so easy to test in our patients. Grip strength, low energy, just got to ask them. Grip strength, you use a dynamometer. Slow walking speed, everybody says we've got to measure gait speed. You can do it in a gait speed test, or you can do it in a tug. Low physical activity, again, another question. What are you doing? Are you keeping active? There are physical activity forms you can use, but I'm trying to make it as simple as possible. And then unintentional weight loss. Again, just another question that you ask. So now you got frail. Are they frail? All right. And then it comes deconditioning, which, go ahead. Do you want to say something? You want to ask me something?
Well, just to recap. So for us to decide if someone falls in the frailty category, I'm just rephrasing. So just make sure I'm saying this right. You can, or you should look at all 5 of these things. Is that what they're saying?
And
so
actually, I can tell you, 3 is what is indicative of frailty. So I'm glad you asked.
So, okay.
So 3 of the 5, they're considered frail. That's
okay. So you need 3 of the 5. So the 5 are the hand grip. So do the dynamometer, and there's a cutoff. I'm assuming score. Always gait speed. And when low energy, there's just a couple questions they ask about their energy level.
Ask low energy. Do you ever feel like you don't have any energy? If they say yes, that's a point. All right. Okay. And then same thing with activity. What do you do in the day? Well, I pretty much sit and watch television. You can give them a physical activity scale, but I just want therapists to do those 5 things. Going into a physical activity scale is a whole nother thing to go into. I think you get enough from just asking it.
Well, I think you're right. I mean, foundationally, let's make sure everyone's starting here, because it could be even something else. And then just the unintentional weight loss. Sometimes they'll say, well, I've been trying. It's like, but have you? Have you just stopped eating because you're not hungry anymore?
Right.
Making sure. So, okay, beautiful. So
And
those are 5 to help you. 3 of those 5.
Yep.
Ask those 5 questions, and then we're underneath the frailty component.
Exactly. And, it's so funny. In conversations, patients will say things like, gosh, in the last year, I've lost about 5 pounds and I'm not trying. There you go. You don't even have to ask.
Or when their pants start to fall down and they're like,
exactly.
Oh, I need a new belt because my belt doesn't fit. It's like,
so many of my patients have like the second wardrobe, clothes that they can now fit. Anyway, and then there's deconditioning, which I think we should check on everybody. You can do the 2-minute step test. Takes 2 minutes. Just have them, march in place, and you measure from their iliac crest to their mid-knee joint. I think most people know this. And then you just put a piece of tape on the wall and you have a march, but it's not a low march. It's a high march. And they do the march and you count the right leg, and there's norms for it. So if you look up 2-minute step test, it's there. It's really simple to do. You can hold on to a walker. You can hold on to a wall. The person, as long as they can, move their legs, you can do the 2-minute step test. If they can't do a 2-minute step test, you can do something like a talking test. You can do a really good one is a maximum phonation test, where you just have them take in as much air as they can, and then they try to say something, usually and you time them, and they should be able to get 22 seconds. And that gives you a little understanding of their pulmonary status. So that contributes to deconditioning. You can also, a real simple one is Cole. Cole does it's a New England Journal of Medicine, 1999. And what Cole did is, you looked at peak heart rate. So you have them walk, let's say, you got your pulse ox on them. You see that they're, 20 beats above resting. You wait a minute and they should drop 12 beats. Oftentimes my patients, the first times I see them, they drop 5. But within a month of doing some cardiopulmonary exercise, they drop, 12, 10, 15 beats. And now I know they're getting more conditioned. So that's a really quick one that you can do to show that they're deconditioned.
So when you said Cole, how do you spell that?
Cole.
Oh, Cole.
Yeah.
Okay.
New England Journal of Medicine, 1999.
Okay. So we might be able to leave that reference, because I think that's in the show notes, because I think, we need simple little things like that in our back pocket that we start to get used to. And the phonation test, I always think I really like the counting talk test. Take a deep breath in, and 1,000, 2, 1,000, 3, 1,000 in one breath. That's similar, right? It's just
similar. The one that I like is, and I thought I had my notes on it, is there's a talk test where you do and I can get you the reference. You do the Pledge of Allegiance. And what you do is, and you have to say something for 10 to 20 seconds. And so let's say, you and I can say the Pledge of Allegiance sitting here, but if you and I started running, in place, and then I said, okay, after doing it for, 30 seconds, I said, okay, now say the Pledge of Allegiance. And you get 3 options. Is it difficult to say the Pledge of Allegiance? Is it, you're not sure if it's difficult, or is it easy? And if you think it's easy, that lets me know that you're exercising right at that right level. So that's sort of a way to can the person do the Pledge of Allegiance while walking? If they can't do it while walking, they're pretty deconditioned, and then you can use it to monitor the exercise. You're walking down the hall with them. They look like they're struggling. Hey, say the Pledge of Allegiance. How was that? Oh, that was hard. All right. So now we're going to slow down, or we'll take breaks or whatever. So it's kind of a way of monitoring. It's not I like the 2-minute step test because it's very objective, and in that test, you got norms, the if we have time for the case, in the case, this guy, the first time I saw him, took him 10 minutes to get to the door. That's how slow he walked. And when he did the 2-minute step test, he had like 35 steps, which is very far below the norms. And as we worked on the bike and walking, he got up to his norms. So it's a really nice test. Of all of them, that's my favorite. So now you have an idea if they're deconditioned. All right. So then the last thing would be, are they sarcopenic? And sarcopenia is just a general, it's like aging weakness. In other words, as you get older, you get weaker. I mean, unless you really exercise and work out, you're going to get weaker. And so there is a tool called the SARC-F, and basically it has 5 questions. One is strength. So how much difficulty do you have carrying 10 pounds? And they can say none, some, a lot, or they can't do it. And then you have assistance in walking. How much difficulty do you have walking across a room? So none would be 0. I mean, all the nones are 0. Some would be 1, and then a lot would be, or unable would be a 2. Then you do rising from a chair. How much trouble do you have going from a bed to a chair? Again, none, some, or unable, or with help. Same thing with climbing stairs. Are you able to climb 10 stairs? None, somewhat, a lot, or unable. And then finally, the last one that's a little different is how many times have you fallen in the past year? So none would be 0. 1 to 3 would be a 1. And 4 or more falls would be a 2. If the person scores a 4 on these, or more on these 5 questions, they are, it's called the SARC-F, and they're at risk for hospitalization and mortality. So it's a good predictor. It identifies it. There's also tools that we use every day that we can then also say they are sarcopenic. The 30-second chair stand. If somebody can't do 15 sit-to-stands and they're a woman, that's sarcopenic. 17 for a man. And that's a lot.
Yeah.
All right. And that's how early we can start picking it up. The timed up and go with a cutoff of 7.5 picks up sarcopenia with a 92% validity.
Oh, that's pretty fast. I mean,
yeah.
Okay.
So, we pick it up early, which is kind of nice. There's also, for hospital patients, there's the Johns Hopkins highest level of mobility scale, which basically just has you go in there, look at what the patient can do that day, and you give them a rating. So it goes from 1, which is if you go in there and all they do is lie in bed, they would get a 1. They get a 2 if they can turn in bed. They get a 3 if they sit on the edge of the bed, and that's even with your help. They get a 4 if they transfer. They get a 5 if they can stand for a minute. They get a 6 if they can walk 10 steps, 7 if they go 25, and an 8 if they walk 250 feet. So at the end of the day, you've seen the person once or twice, doesn't matter. You give them the highest level of mobility. So let's say with you, they were able to transfer, and that was it. So they'd get a 4. And again, as they get stronger, you could do that. So that's meant for the hospital. They even have one for the ICU that was done by Dennehy. And the lady that did this, so nice. I called her and had her clarify for me. Such an easy test. 4 things. All right. Because her feeling was people in the ICU really couldn't tell, the functional status. So first of all, unable, sit to stand.
So wait, what's this one called? I'm sorry.
PFIT. The
PFIT.
Patient Functional Independence Test.
Okay.
And so the first test would be a sit to stand. And we don't count necessarily. We just, can they do it? All right. So they get the highest that they can do without assistance. 2, they would get if they need assist of 1, 1 if they need an assist of 2, and 0 if they can't do it at all. Then you have them step in place. You don't have a march. All they have to do is be able to lift their foot, transfer weight right to left. How many they can do in a minute. They get 3 points if they do 80, 2 points if they do 50 to 80, 1 point if they do 0 to 49, and 0 if they can't take any steps. And then the last 2 are so easy. You measure shoulder flexion, you measure knee extension. 0 for both of them for grade 0, 1, or 2. They get a 1 for grade 3, a 2 for grade 4, and a 3 for grade 5. And it's a really simple test. So you add the score together, and as they improve, they get better. It doesn't have predictive validity, but it really lets you know, obviously, if someone on a PFIT has a 0 or a 3 or 4, they're pretty low. If they have, a 12, that's a great score. So again, it sort of lets you know their fitness level in the ICU.
So, okay. So let me just summarize. So the Johns Hopkins, what was it? Johns
Hopkins highest level of mobility.
Highest level of mobility. So yeah, I'm aware of that one, and you can provide physical assistance, and it's right, and it's just the level and that functional piece. So that's just a nice way to be able to communicate. The PFIT, I find that fascinating because again, that score, what a great motivator for the patient, because they're in the ICU and you scored this, and you can break those down into other pieces, but from like a knowledge of results and motivation, you put their score up there and you're saying, what do you think about this score? Which one do you think we can improve on this time or today? Because those are the activities you should be working on anyway, right?
Exactly. So it takes like a minute to have a PFIT score, and I know therapists in acute care are just so pressed, especially in the ICU. Here's something that takes hardly any time and it gives you some good information.
So those are the ones I hear from, like, what tests should we be doing?
Yep.
Thank you for that, because I'm going to pass that along.
Yeah. So,
look that up and pass it along.
Yeah. Some of the universities have YouTubes out there of it. So you can actually see that they have students doing the PFIT. If you just go into YouTube and you put PFIT, there's like a 15-minute video that shows you how to score it. Very, very easy. But the article is by Dennehy. It was in the PT Journal in 2013, Denehy, PT Journal 2013. So it's been around for a while.
But it's hard to get information out there. And I'm just thinking max phonation, that goes across the board and is focusing on breathing. And during all of these tests, whether you're doing the 2-minute step test or just a walking test, we can still be having the pulse ox on there and keeping an eye on their heart rate. And we could be comparing and trying to see what their trends are. And the Sarc-F, that's just great because now people can have something to justify more therapy, right?
Exactly.
Because that puts them at risk when they have sarcopenia, which would put them at risk for falls. Is that accurate?
And yep. Oh, definitely. When you're sarcopenia, definitely at higher risk for falls. Yeah. And the thing is that the Journal of Geriatrics just did a study that came out in 2024 that said that therapists are aware of sarcopenia, but they don't test it because they really don't feel like they have any tools. So I'm so glad we're having this talk that people can go, oh, wow, I can do a Sarc-F. Actually, a really fast one that just came out that I haven't used enough to really lecture on it or talk about it, is you can measure people's calf circumference. But there's some false negatives because if you have somebody who's heavy, and they're weak, that's going to be a false negative. But if you now, and ever since I read it, I only read it a couple of weeks ago, I start looking at, my patient's calves and I go, my goodness, and it actually is a pretty good measure. So there'll be even more faster measures, I think, coming out. And again, if you want to justify seeing your patients, these are some really good tools to help you do that. If you say this person's deconditioned, frail, sarcopenic, and, they're having problems with back pain and falling, my gosh, you've built a case. I love your point there.
And the way you just said it, right? We need to use our skilled therapy. We need to be documenting that and saying sarcopenia and the deconditioning and this. We need to make our case so we can keep them longer. Just because they walked across the room okay is not for us to know that they're safe out there. And we need them as long as possible. And I know that's really hard. So having these quick measures or, just appropriate measures for any level just is amazing. So I love all of these. And again, some of these are very simple. It just is getting the repetition and kind of getting them into your little schedule, right?
Yep.
So outcome measures, check, like stunning. Now, what about interventions? Like, can you give us some highlights of like recent research in regards to that intervention?
That's my favorite thing.
Here, Carole, I think we're
just building up to this. No, you know what? I am an intervention junkie. I every morning I must read, 5-10 articles. And when I see something new and creative, I'm like, ooh, I get so excited. So, nothing makes me crazier than people thinking, well, they can't really do anything. And there's so much you can do for these people. You just gotta, and I know high intensity is important, but you can make high intensity for patients functioning at a lower level. All right.
Yes,
So let me
absolutely.
just start with number one is I think we've got to use a board. I am a huge fan of the board card. Here's, I literally carry it with me. One of the therapists I work with, there it is. I wear it on my forehead now. One of the therapists I work with has it on the back of his computer case so that he lifts it up when he goes to do his notes and the patients can see it so we can ask them about it. It's brilliant. But if you can get your patients working in the area of moderate, somewhat hard to hard for aerobics. You're not doing high intensity, but you're hitting that aerobic to work on deconditioning. And then if you work on the hard, really hard, and there's studies that show you can do a progressive resistive exercise program just using the board. So you have the person do it and you say to them, all right, how does that feel? Like you give them the weight, so they're lying in bed or sitting in a chair, whatever you do, you put a weight on them and you ask, so how is that? Is it easy? If they say, yeah, it's easy, you got to put more weight. If they can barely move the leg, obviously that's too much. If they can take it through the arc of motion, you're going for anywhere between 8 and 20. And somewhere in there, you say, how is it? And they go, yeah, that last repetition is hard, really hard. And if they can do it, you have hit it on the head. All right. And that means, changing the color of the TheraBand, changing the weight, making it so it is a challenge for them. So if you find that they're saying, it's somewhat hard, in 2 sessions, you got to up the weight. And I review notes for cases and for insurance companies. And I love when I see a therapist saying, patient's Borg response to the strength training program is, a 9, so it's a 9. I'm sorry, if it's a 9, you got to lower the weight. It's a 0 to 10 scale. Sorry. And if it's a 5, then you have to increase the weight. So, if they say the patient's at a 9 and then it's a 9 again, we'll decrease the weight. Patient says it's a 5, next time we'll increase the weight. So, you don't have to write all those words. Borg 5, increase weight next time, make it faster or whatever. You don't have to write tons and tons of words. So don't forget the Borg. People like this rate of perceived exertion approach. They've done studies on that as well. And then, Martinez did a study in JAMA, of all places, the Journey of the American Medical Association. I mean, really, they have some good stuff that we don't even see. And they took acutely ill older adults and put them on a program for the 4 to 5 days we were there. Now, I know a lot of our patients aren't there that long. They try to get people out, but we do have some older patients that stay in the hospital longer. Yes. And those 5 days can be deadly for them. So what they did here is they literally took these people down to the gym and they had them do squats, sit to stands, leg presses, knee extensions, bench presses, and they had them do 3 sets at a 30 to 60% of a 1 rep max. So it wasn't high intensity, but it was intensity. And then they had them do semi-tandem, line walking, working on the base of support, uneven surfaces. And then they saw them in the afternoon. In the afternoon, they had them do a lighter type program where they just tried walking or some functional tasks. But it says to me that there is a lot we can do even with acute care patients. So I love that one.
That's a good one. What was that? What was the last name again on that one?
It was Martinez, and it was in Journal of the American Medical Association, effects of exercise intervention on functional decline in very elderly patients during acute hospitalization. And it was JAMA 2019. But I think the one that's much more famous and I love is Gustafson's Eye Stronger program. And that came out in 2000 in our journal in physical therapy. And it was done 5 times a week, and they showed improvement in gait speed, the SPPB, the short physical performance battery. They improved skilled nursing length of stay. And so what they did is they divided the treatment session into thirds. So 1/3 of it was strength training on the 8 rep max model. So I love 8 rep max. That's sort of my go-to. I want to fatigue myself and my patients at 8 rep max.
Agreed.
So when you think you're doing it. I got myself a tonal and now I really am doing it. But, I was lifting 5 pounds in my biceps going, yeah, that's good. Now I'm doing like 25 pounds. You got to push yourself. So the 8 rep max, the person should start fatiguing. All right. And what that means is they don't go, oh, I can't do it. Maybe they get that last rep and they're shaking or they're going halfway through it. You're there. Okay. And then they did a third, and this is a part that's priceless, doing transfer training or bed mobility to fatigue. How often do we?
Yes.
Yes. How often do we do bed mobility, but we do it once? Let's roll in bed. Let's get out of bed. They have them do it till they fatigue. So roll, keep rolling, roll, keep rolling, roll. Okay, you need a break? No, keep rolling. Roll to the left, roll to the right, scoot up and down. Fatigue them or have them transfer. Do sit to stands or transfer from the bed to the chair until they fatigue, till they can't do anymore. Or a bridging progression. Go ahead.
No, I just want to emphasize this point because I am so with you. We get them up once and then we're like, we practice bed, and sometimes we're tired, but yeah, lay down. Let's do it again. Let's do it 3 times without thinking about it. Like just get them 1, 2, 3. And it's fascinating because we need that for repetition to realign, not to mention strengthening, not to mention retraining the movement, and just doing that over and over and then having them do it faster or help them and have them do it faster. Like it's fascinating. Trust me, I remember doing this when I was in the hospital where I just thought once I had to get them up into the chair. Like I was thinking of the end the whole time instead of taking the process and turning that into the intervention. That's just exciting.
Yeah, and I was so excited. Yeah, so excited that don't. I agree. I'm so excited somebody did a study. And then here's the thing, I'll say patients go, I'm tired. And I get it. You're sick. All right. But use your pulse ox. If their heart rate's not going up, they're probably really not tired. They just don't want to do it. So I said, yeah, we're going to do it till your heart rate goes up. All right. So, that's kind of rough that way. But I tell you that when the session gets done, they look at me and say, thank you. Actually, I felt like I did something, so that's the 1/3. And then the last third is they have them do neuromotor training. So, and then again, they try to fatigue them at 8 reps. Now that's the hard part. What can we do motor learning to get them to fatigue at 8 reps? So one of the things is multi-directional stepping. So if I just step out a little bit and come back, I'm not going to fatigue at 8. But if I really take a big step and you put a piece of tape there and you make me do it 8 times, in different directions, I will fatigue. Who wants them doing like these little tiny things? It's not doing anything. Having them do step ups, if it's a little step up, for some people, a little step up is enough. For others, you might have to get a pretty big step up and down from the floor. And so, for some of my patients, just getting a hand on the chair, a hand on the seat, and maybe 1 knee on the floor and getting back up, 8 times is enough. It might just be hand on the back of the chair, hand on the seat, back up. And, that might be enough for somebody. And you might have somebody who gets all the way down to the floor and back up again 8 times, or somebody who can do a burpee, all the way up and then you jump in the air and jump back down, whatever fatigues you at 8 times. And if you can do a burpee, and we're not in the hospital here, but, put a weight belt on them or something. So I thought it was an incredibly creative program, and one that I absolutely love. So that's the I Stronger program. Carbonis Valdez. Also, this is, I see some patients in hospice, that the family member wants them exercising and they can't even get out of bed. But, after doing some exercise with me for even maybe a half an hour, and some breathing and we do a little meditation, they feel so much better just from, getting some oxygenation. So Carbonis Valdez is really good. And this article came out in 2015. And it works really on the core. So there's a supine part and that's if somebody can't sit, where you just have them do anterior, posterior tilts, 10 reps, 2 sets. Then you have them do bridging, and you do bridging progression where you have them bridge and then bridge and with a band and unilateral bridge. Then you have them doing some trunk rotation, some lower trunk rotation, and then bridging on a ball. And then if they can do that, you have them do sitting. And the sitting progression I love because most of our patients can sit, and just have them do flexion extension of the lumbar spine, but fulcruming, not letting them bend over as they do it. So they really work the core, anterior, posterior tilt sitting, lateral flexion. And you guys, I know you've been sitting for like a half an hour at least. So put your hands on your head. I hate to let people sit, and do this with me. Keeping your back as straight as you can, I want you to try to bring your elbow to your seat, all the way down to your seat, and then bring it back.
Why?
All right? And then do
You're
it to
better
the
at
other
this than
side.
me.
Yeah. No, so I'm just saying.
I'm not gonna fall out of my chair.
Yeah, no, don't fall out. But on a mat table or on a bed, you can feel your core muscles coming in. So it's a really good one. Upper trunk rotation, all right? And then lower trunk. So as you're sitting, just move your knees back and forth. Do it with me. And what you'll see is you'll get lower trunk rotation. And you, again, 2 sets of 10. Another great core that Cabanas-Valdez does is reaching forward. So unsupported, you're going to reach forward, you're going to reach to the side, and you're going to reach backwards. Again, 2 sets of 10. That's the ticket, is you got to do, if they're not heavy resistance, you have to do more repetition. So that's Cabanas-Valdez. And then
So wait. So it's and I'll let you finish the last one. Just because now you're doing such a good job about talking about. I mean, really, you've just been giving us examples of translating all of this into the research. And I wanted to say earlier, it's just some of this is that you really are showing the patient that they have the capability to do it. I don't think they realize they have the capability to do some of these things. So I just think it's great when you're pushing them and you're challenging them and they're saying they're tired. They just don't realize you can do 5 more. You might be able to do 10 more.
Exactly.
I don't know. I'm thinking you could even do 15. So, doing the visual to market. And then this Cabanas article sounds like, so these things that you're listing off, are they listed in the article?
Yeah.
Okay. Because to me, it just, that, I love an article that actually has some really specific, like I'm writing that one down right here.
Yeah. No.
They have specific things and you'll be like, okay, yeah, I do that. Okay, I do that. Oh, I hadn't thought of that. And what if I added TheraBand, or what if I added their eyes closed, or what if I added, there's just so many, an unstable surface, or them, whatever, be unsupported. Like there's so many different options.
There are. And I got to tell you, nothing makes me more angry than to read an article and it doesn't have their intervention. I mean, I wouldn't.
Conventional compared to conventional therapy. It's like, okay, thank you. What does that mean?
Or they say, they give you something that doesn't describe it. You should be able to replicate what they did in the study. Yeah. I wouldn't publish it in my journal if they did that. So I don't know how they got published in some other journal, but these are great because they're very specific. So I think this might be the last one I have for you. This is Pedersen, and Pedersen actually did a progression of a sit to stand, which I think all of us know. This was a 2015, and this was a sit to stand for hospitalized older persons. But man, I use it for everybody. Basically, you first see if a person can get out of a chair without using their arms, and you just, if they do and they fatigue at 8, that's the right thing for them to do. There are some protocols that have people doing sit to stands for a minute, but if they can't do it that way, then you progress it downward. In other words, having them get out of the chair with 1 arm, and then having them get out of the chair with 2 arms, having them get out of the chair with the help of you, and then finally, if they can't do that, just long arc quads. Or you can progress it the other way, which would mean if they can do it without their arms and 8 doesn't fatigue them, have them do it with what I call a kickstand. So you put one leg forward, so it's a little harder to get out of the chair. And if they can't do it like that, you guys should try it. Try to get out with 1 leg. All right. Sit to stand on 1 leg 8 times on each side is definitely going to be tough. If that isn't tough, you can use a weighted belt to get the benefits of that. So that's Pedersen's, which I really like because it's a great progression. And there's really good. There's more. There's an Invest program that came out. I know I have way too many things here. 2009, but basically they use a weighted vest and do things like tricep dips, back extension, one-legged standing, step ups. So there really are so many different things. There's like so many things out there. And I don't want to make you crazy with all of these, but I think they're great. I mean, this one by Mohammed has people doing, and what's interesting about this one is you do the concentric quick, which I'm so excited to finally see. Power, yeah. So many of the protocols don't have power in them.
More power.
Yeah, so doing concentric quick and then eccentric slow. And you do 2 sets, and you do things, like I said, like back extension, one-legged standing, toe heel raise is such an important exercise. And then dorsiflexion is important too. So you put weights on the front of the foot, or use a rubber band resistance, tricep bridging in a chair. So you bridge with your arms and your buttocks. Wall push-ups. Oh my gosh. All my patients love wall push-ups. They do. And again, the wall push-up can be progressed. So if 8 at the wall are easy, you go to a kitchen top, and then you go to a chair, and then you go to a step, and then you go to a floor. And you should be, fatiguing at that point. So that's also really good. There's also, you can just do functional training. And this one study had people just doing things like stepping on and off a bench, walking through a curved pass, picking objects off the floor, avoiding articles. So again, don't forget function, as long as you make it difficult for the person so that it's challenging. So those are just some ideas. I mean, I have
just one or two.
I know.
I would throw out there, these are all really great articles. Don't feel overwhelmed. First of all, the excitement is that there's so many different things out there. And if you haven't heard of one of these articles, it's just such a great thing to go to. Or if you're feeling overwhelmed, this is what's a great time to give the student that you have come to work with you, you give them, oh, why don't you check out one from this list? And why don't you check out one and highlight your 3 favorite things? And then let's talk about how we could integrate that today. Like, this is a journey,
Yep.
So we want to enjoy it. And like, I can see we're similar in regards to our excitement about new treatment ideas and just another approach for a person who couldn't move. And now we're showing them they can move. And so, like, I just love all of this because all of those, I mean, you already are translating it into the clinic. And so I'm curious about like word choices, or if you have any words of wisdom in regards to talking points or word choices or strategies of how you get buy-in, because we can do a great job and we have different things to see what resonates with them. What do they do well? They love wall push-ups, and let's go at it, and get the stretch and get the power. But do you have any insight into how can we get our patients to carry over with these things?
Yeah. So the American Geriatric Society's come up with the 5 M's. So you got your medication, mobility, medical, complexity, medication, and matters most. And to me, matters most is the one that matters most. So I try to get that right off. What is it that's most important to you? And that is our guiding light. You want to be able to, pick up your grandson, or you want to be able to, not shuffle when you walk, or whatever it is for that person. That's going to be the guiding light. And so, I work on that. I also think, sustainability, we are good at what we do. We're not as good at selling the benefits of what we do.
Agreed.
I tell my patients about these studies. I tell them about other patients who did this and got better. That's some of the things that I do to motivate. I'll even talk to their family members. Is there something that we can do that would help? I like checklists of exercises for them to check off. Those help. I also have a thing that I call an action planner, which, it's like, how confident are you that you can do certain things? And what would you do? Like, let's say it comes to the end of the day and you haven't exercised, what's your alternative plan? Oh, I'll do these 2 exercises, as long as you do something, because oftentimes what we do takes more than just being with us.
Right. Exactly.
So we really have to sell it. And that's hard. I think, I don't think we would be in sales if we were good at that, but I think we have to sell what we do because it's good stuff.
Well, and that, the enhanced expectancy. I mean, there's literature to support almost everything that you've said, just your strategies. You just gave some really nice, explicit strategies of how to translate. And I think the end in mind and what matters most, if we are always understanding that and they know that we're working towards that, you're going to get buy-in. I mean, that's just really exciting. Yep. So, okay, because I want to make sure we have time to get to a little case because you seemed very interested in talking about that. So looking at our time, let's first give us your top 3 actionable takeaways for clinicians to put into practice, and then I want to hear that case.
Okay, so you want the top 3 first?
Yes.
All right. Let's see. Oh, dear. Well, I want them to be able to recognize that their patients, are more than just the diagnosis they're seeing, that they might be frail, they might be deconditioned, they might be sarcopenic. And then that there are quick, easy things that they can use to see if they really are. And thirdly, there are tons of great ideas out there that they can use, so that they're trying, I would love to tell you Cabanas Valdez works for everybody, but it doesn't. All right. So I try different things. And if it's not working, I switch to something else. So yeah, there's plenty of different things you can do to get the results, that you and your patients want. So is that 3? That was 3. Right?
Yeah, no,
okay.
Those were perfect. Because now can you tie that into your, your case? Because I was excited.
Okay. So do I get to do 1 case or 2?
Let's start with 1.
Okay. All right. Then I'm going to pick this one first. So This is a gentleman, we're going to call him Bert, and he is 77 years old. He relayed a history of having several mini strokes back in the 2000s, and with each one he got a little worse, but he never had your classic symptoms. He had some weakness on one side compared to the other that he's noticed throughout the last 10 years, but he's been going to therapy for 10 years. And by the time I saw him, he'd gone from walking a couple miles to pretty much only being in his apartment with a cane. And his concern is that he's very bent over and he wants to walk straighter, and he wants to walk faster and wants to get back to doing what he was doing, before all the strokes. So, his heart rate, blood pressure, they're okay. His oxygen saturation. I used the wall occiput distance to see what his posture was. And when he actually, it's fascinating. He actually can get his head to the wall in the proper position.
Good.
But that's not how he walks. He walks with his head like 16 centimeters from the wall. So it's not, he has the potential, which is why you have to get him early. But he doesn't have the muscle strength to hold his body up. So when I did a back extension test with him, he was barely able to hold his body in the prone position up for longer than 3 or 4 seconds. Hence, when he stands up, he's not going to be able to do it. He's very tight in his shoulder. He has a shoulder OA, very limited in rotation, only able to balance on one leg for 0 seconds. Tandem walk, he makes 10 mistakes. Timed up and go, norms for his age are 7 seconds, and his initial score was 39 seconds. Endurance test for the 2-minute step, he scored 62 steps. The norms for his age were 88. Weakened grip by 5 pounds each side. Weakened rotators of the shoulder, both sides. Only able to go up on his toes for the single leg plantar flexor test 0 times. Norms were 25. On his SARC-F, he scored a 6, which means he's weak. On the Freed, he scored a 4, which means he's frail. And the deconditioning, I used a 2-minute step test where he scored a 62 and it should have been 88. So I put him on a biking program. He got a horizontal bike and we worked on a progressive biking program. I put him on the Botman's protocol for his posture to start strengthening those back extensor muscles. And we started working on a high-speed walking program to get him to walk a little faster. with his gait. So that's quick what I did.
What,
Go ahead.
what was it that you used for his posture? What?
It's the Bautman's protocol, Bautmans. Oh gosh, I'm trying to remember the year, like 2000 it came out.
Yeah.
It's a great protocol, and it's so therapy perfect because you see the person, 3 times a week, then twice a week, then once a week for these different things. And it has extension exercises over a chair and lots of things you can do in sitting, because getting in prone for him when I wasn't there wasn't going to happen.
Right.
So these were a lot of extension exercises you can do in sitting, which really helped. So I had him do the Bautman's. And again, that's sort of a quickie of what we did, but I know we're running out of time, so I want to.
I'm just going to tell you, Carole, we're going to have you back. So we'll save the second case for when you come back, because I'm thinking you gave us so many different treatment ideas, and I have a feeling you have a whole bunch more that you could have shared. And what I don't want to miss out on is your final words of wisdom or inspiration, because that's sometimes my favorite part.
Oh, okay. Yeah, no, I just want to tell the therapists that are out there that, you're really in a great profession. You're helping lots of people. I mean, to me, it's not work unless you'd rather be doing something else. And I love helping these people get better, and, take that in. And I'm hoping that someday we'll get paid more and we'll be recognized for all that we do. But stick it out. It's a wonderful profession.
Yeah, absolutely. Well, I can't thank you enough. It's been just a pleasure to talk with you, Carole. And that's all we have time for today. But thanks again. Shout out to Dr. Carole Lewis for the insight and clinical takeaways related to deconditioning, frailty, and sarcopenia. Thank you so much.
Oh, you're welcome. It was a pleasure. Thank you.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.